Hey, good morning. It's Wednesday, August the 24th. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. It's been 6 months since we've had a status report on COVID in the metro and the region. I told the Chief Medical Officers, we need a little more COVID so we can talk and bring everybody together a little bit. No, actually, that's just a joke. Today, we bring you another news and community conference with 12 Chief Medical Officers and infectious disease specialists, including myself, from the metro and across Kansas. Just to clarify, I'm not the infectious disease specialist. I'm just kind of a goof. Last February, the University of Kansas Health System had 174 patients. Last January, we had 225. And the count for many of us was going up. Transfers were tight, staffing was low, supply chain was challenging. We'll look at where we've been, where we are today, and where we think we are headed this fall. Over the next 45 minutes, we'll hear if there's been any improvement in the healthcare system around this state. Not just about COVID, but really about all things health. For a long time, it's been under a great stress from the sustained period of high transmission, workforce depletion, and all the other things that are affecting the world around us. After we hear from our physicians, we'll open this up to reporters and to the community for questions. Members of the community should put their questions into the chat feeds in Facebook, YouTube, Twitter, or email us at medicalnewsnetwork@kumc.edu. Alexis Del Cid will monitor those feeds for questions. Let's begin. All right, here's where we are this morning in the region, according to data from the Mid-America Regional Council and the New York Times heat map. First, the Mid-America Regional Council. You can see from the lab that it's been 6 months since the last report. You can see what's been going on. Daily new cases, 239. Daily average new hospitalizations, 72. Daily average new deaths, 1. A lot better than where we were at the height of this pandemic last January and February. Here's a look at the national picture in this current heat map from the New York Times. If you remember this map, I mean, I love the New York heat map, but if you watch it over time, it has been slowly lightening up, although there is still that kind of southeast and then Atlantic region state, a darker purple, but even that's better, and we're better in the far west for sure. So how are we doing here at the health system this morning? Dr. Dana Hawkinson, Medical Director, Infection Prevention and Control, and a true infectious disease doctor, unlike myself, is joining us to give us the health system numbers, plus the latest on monkeypox. Hawkeye.
Yeah, hey, I think we're doing pretty good. Down to those lower 20s now. 22 active infections, 3 in the ICU, 1 on the ventilator. Still 21 in that recovery period. I think that MARC data, the Mid-America Regional Council, looks good. We know nationally we are down. I think we have peaked and are on that decreasing trend. We have 90,000 cases per day reported in the United States. But of course, I think hospitalizations, we've hit a peak and are on that downtrend as well.
Yeah, I think that is good news. And now developing this morning, the New York Times is reporting that the bivalent COVID shots could start shipping next week, Hawkeye. And you listened to a podcast we were talking before the program with Fauci saying the same thing.
Yeah, absolutely. Dr. Fauci was talking about how probably that first or second week of September, they'll actually be ready to give the bivalent vaccines around the nation. For Pfizer, later in September was Moderna. So hopefully we will get these and get those into arms.
Some of the mice model data suggests better protection, but we were also talking about the importance about T cell and B cell and whether or not it's really going to be more about antibodies or more about those T cells, which look like they are more preserved across all the variants.
Yeah, just looking at an article from a T cell scientist, Dr. Alessandro Sette, yesterday, and it looks like, and this is what we have seen, and I think this is why we haven't seen the large increase in hospitalizations compared to that Delta Omicron surge. We still have those preserved T cell functions, which have really seemed to be consistent throughout all the variants. So that is our one saving grace. That occurs whether you've been naturally infected or, of course, as we have always said, the safest way to that immunity through vaccination.
Okay, monkeypox?
Monkeypox, monkeypox is still here. Our cases are continuing to increase around the nation, over 15,000 cases now, but also locally in the state of Kansas and, of course, Missouri. We are still giving out vaccine. We have vaccine here at the health system. The other vaccine rollout to other places around the community, I know Kansas City was getting some, is still coming as well. So I think we are hopefully able to get a handle on that. We believe the epidemiologic curves are decreasing and trends are decreasing as well, but really continuing to give that information to those high-risk groups, get that vaccination into those high-risk group arms as well. I think that's going to be vitally important. Hopefully we will start to see a downtrend here of monkeypox as well.
That would be great. And I think that the first monkeypox case has been discovered in Monkeypox County, in Douglas County. And when we get to Dr. Jen Scrimshire from Lawrence, we're going to ask her about that. So that's a little heads up to you, Jen. First, though, let's bring in Dr. Richard Watson, the co-founder of Motioned. This is a company that created the Mission Control app, which has been enormously helpful. It's an app that the Kansas Department of Health and Environment uses to connect rural hospitals when trying to transfer patients. And we were talking just a little bit about this before the program. Dr. Watson, you've been keeping track of bed capacity during this pandemic. How are things now compared to 6 months ago when we last spoken with you? Have things gotten better? Are we back to normal?
Great question, and thanks for having me this morning. If you put up the graph, that would be great. I think as we followed it over time, we look at capacity on a 1 to 3 scale, with 3 being no capacity whatsoever. This graph tracks from last year over to the present week and is updated real time. We do pull the data by phone polling hospitals, and it compares the number of beds needed with the capacity itself. You can see through the summer last year, we were at a certain baseline, and then come in the fall, we had a real increase in the surge that everyone talks about through the November, December, January time period. Then we dropped back down as we went into the April months. The problem was we never dropped down to the baseline we had previous, and that's become the real story here. If you look at the bar graphs, the darker gray represents COVID as a percentage of the beds needed. Even through the current small surge, we did not see the percentage increase that much. These are not COVID beds that we're needing right now. We need beds across the board. And the story here is going into a fall, which we're really unsure of what the picture is gonna look like. The system is already at a higher level of capacity than it was even last year as we went into this time period. So without a doubt, even without COVID, without any of the other surges, we're going into the fall in a precarious position, no question.
You know, and I think we feel that, and we'll get a sense of that from our CMO and ID docs around our region. But I know we feel this. Our census has been really high, and we're not able to take as many transfers as we normally do. You know, we're usually taking 40, 60, 70 transfers a day, and we're still in the low teens, which is where we were back in January and February. And it's not that we're not full. The problem is we are full. And so it's like there's a lot of sickness out there. And I'm not quite sure how to all explain that. I could like to blame all the infectious disease people on this call for that, but I'm not sure it's only their fault. So we're going to have to talk about that. We're also going to talk about staffing, because I think the lack of staffing, and not everybody can staff all their beds. We just don't have enough people to do that. I think that could create situations that could be challenging this fall. Dr. Watson, do you normally see an increased number of transfer requests in the fall?
Oh yeah, the normal patterns of disease as kids go back to school, as activities change, as the weather changes, just dictate that we're going to see a higher level of need across the system. And I think you're right. I think it's not only attrition of the healthcare providers, but it's also the fact that there aren't as many beds being staffed at this time as there were last year. It is a staffing story at this moment, and it's a very strange intersection between a very novel, interesting disease process and a health system that's just really teetering here at the moment.
You know, and thank you, because I think that's how it feels to those with boots on the ground, I believe. We're hear from other folks here in just a moment. But I think there may be some reporters on the line today, but I'm a little nervous as we head into the fall. And it's not just COVID. I mean, before when we had 55 patients, we would have been, oh my God, we have 55 patients with COVID. Well, now we kind of got used to, all right, we have 55 patients with COVID. Right now, that's what we're going to have. That's just normal now. But overall, I'm nervous about hospital capacity. And Dr. Watson, are you seeing people with time-sensitive diagnosis lagging in rural ERs, unable to access higher levels of care?
Yeah, I think that's the ones that are the most at risk here. You've got a lot of things that are jamming up the ER. You have not only times for EMS, we've got healthcare provider issues and supply there as well. There just aren't as many EMS resources for interfacility transport as there were before. We've got a behavioral health backlog that is adding to this and consuming staff time. We have transfer issues related to that as well. Every aspect of actually the logistics of doing emergency care have been changed, and that's what we're dealing with right now.
Okay, so I've just got a prompt. They want us to go ahead and move into reporter questions, so let's do that next, and then we're going to get to our CMO. So reporter questions on the line. Nope. Okay, here we go. All right, we're going to start going through the inpatient numbers across our metro and the region. I'm going to start with Dr. Kim McGow, the Chief Medical Officer for HCA Midwest Health. Kim, how are things for you guys, their COVID numbers, and how are you doing with capacity?
Good morning. Thanks for having me. Our COVID numbers are pretty much in line with everyone else, I think, in the market. We have 45 patients across our system this morning, only less than a handful in the ICU and none on ventilators. So while we do have some COVID presence in the hospital, it's not near as much of a burden as it was, 6 months ago. Our challenge is, as you mentioned, Steve, the staffing and capacity challenges. We continually monitor and work the bed capacity real time throughout the day and night, every day. But we may have closures based on lack of staffed beds, but we literally hourly are opening up a bed or two here and there just to try to relieve some of the pressure on the system as we can get staffing. But it truly is right now a staffing issue. We have seen a little bit of relief in that over the last couple of weeks, but still continue to deal with that on a daily basis.
Yeah, I think, Kim, this is going to set us up for a difficult fall. Thoughts? And winter.
For sure, we are concerned. We've had multiple conversations here at the division level amongst our leaders about how we can address that and actually have begun putting into place what we term a seasonal plan for staffing, particularly for nurses, but other caregivers as well, to try to accommodate what we anticipate to be a rise in census as the fall months come on and potentially a flu season that could add to that volume as well.
Thank you. Dr. Lisa Hayes is a CMO at Advent Health Shawnee Mission. Lisa, how are things at Advent?
They're definitely better than they were last time we talked. Yesterday we had 11 active inpatient COVID patients and one that had cleared their infection. Our staffing numbers, we did have 12 staff members with COVID yesterday. 10 of those were clinical. Our big concern continues to be staffing. We've had some challenges over the summer with staff having left the nursing profession and trying to hire new graduate nurses as well as experienced nurses. We're starting to see some light at the end of the tunnel, trending up in our staffing numbers, but still challenges getting patients through our ED and up into the floors, into the units.
Yeah, I think, are you able to accept as many transfers as you normally would, or is that still reduced? Because I know ours are reduced.
I would say ours are reduced or delayed. It definitely takes longer to get patients moved from those outlying freestanding EDs as well as community hospitals that are wanting to transfer in. But we prioritize like always. Yeah,
you bet. Dr. Jennifer Scripture is the infectious disease physician at LMH RAID, but she's also the Deputy Public Health Officer for Douglas County, where they just reported their first monkeypox case. I take it you're going to tell us a little bit about that, Jen, as well as how are things going with COVID?
Sure. And I'm no longer the deputy, Dr. Stites. I'm the actual local health officer.
Oh my God, are you really? So Douglas County is in your hands, Scripture? Is that what you're telling me? They're in your hands?
Yeah.
You're very capable of hands. That's awesome. Congratulations.
Thanks, Stites. Our inpatient numbers are actually back up. We have 9 active, 1 in the ICU, 1 recovering. We also have a death recently. I believe that was last weekend. Staffing wise, we're down. Our numbers are down. We finally dropped down to 10 positive employees, which is a good sign for us. And I think if it wasn't for school starting, I would say it's a good sign for the community. As with everyone else dealing with staffing issues, and not only, attrition, but also re-entry, training new staff. And then there's a lot of shuffling. I think people are moving within the system to different positions. And so there's a lot of change broadly across our organization. Beds as well. It seems on some days like we're seeing winter numbers, and it's not necessarily COVID, but it is definitely with sick people for various reasons. In regards to monkeypox, first confirmed case. We've been vaccinating people and getting people in for both the post-exposure as well as the PEP++, with, I think maybe only the ID people on this call would be familiar with, but definitely getting people vaccinated. Thanks to the state for getting us that vaccine, and also thanks for allowing us to do more than one dose per vial with the dermal vaccination. So.
Yeah, I think that is good news, and I know it's really helped stretch the supply across the country. So, well, thank you, and congratulations on your new position. Speaking of new positions, our good colleague and friend and Chief Medical Officer at Liberty Memorial Hospital is Raghu Adega, who is also the interim president and CEO there, but he doesn't have his own parking spot. Dr. Adega, can't you fix that for yourself?
Thank you, Steve. I'll work on that right away.
Yeah, stat.
Good morning. Well, at Liberty, actually, our numbers, just like everyone else's, has been improving lately. This morning we have 11 inpatients with COVID, 8 of them are active, and 1 is in ICU on the ventilator. But as everyone else mentioned, I think we have ups and downs, especially with capacity issues, either related to emergency room being full or operating room capacity as well. And most of that relates to staffing. And we do have currently 9 employees out with COVID. While this has come down, it hasn't stopped. And I looked at the total numbers, 859 so far since we started. That's almost half of our entire staff, even though some of them have had 2 or 3 times. But that's a large number. When you look at, they're out for a week, that takes out a significant portion of clinical staff. So, but overall, numbers are getting better. Capacity issues go up and down. I think this morning we're okay.
Yeah, well, I hope you can stay okay, because I think people need beds in Kansas City. So, Dr. Kevin Dishman is the CMO at Stormont Vail and does a great job there. Kevin, how are things at Stormont? Hey, Kevin, you may be muted still.
I don't know. Can you hear me now?
Now we hear you. That's awesome. Don't worry. It's only been 2.5 years. Oh, now we can't hear you.
How about now?
That's
We have technical problems. I would echo what everyone else has said. I think really for us, numbers-wise, we're seeing the same as everyone else. We have about 15 inpatients, 1 in the ICU. I think the big thing that we've all realized is that COVID unmasked a long and worsening problem in healthcare. Staffing is a problem for all of us. Staffing is a problem across the country. No one is immune from this. As Dr. Stites and others have echoed, we as a safety net for our referral hospitals, for our community hospitals, our rural hospitals, are not able to keep up with the demand. For a long time, we have, I think, avoided this question in healthcare, and it's been coming, and COVID unmasked that. And we are presented with a national challenge, which must have national solutions at this point. We will take every opportunity we have to work with the American Hospital Association, the American Medical Association, my personal professional association, ACP, and as I know all professional associations are, to sound the clarion alarm of where healthcare is in America and work together with solutions. 20% of people have left the profession, and that's doctors, that's nurses, that's ancillary staff, that's administrative staff. And rebuilding is going to be difficult, and we cannot do it alone. We must call on our national leaders to step into this space and to help us retool and remake the healthcare system in America. And I think groups such as this one today are extremely important as we unify our voices to, again, sound the alarm of where healthcare is and the help that we need. We're going to continue to see these challenges. We're going to continue to see these bed shortages until we can find a way to all work together to address the many, many issues that we face. The staffing crisis, which is complex in and of itself, healthcare delivery in America, the payment system for healthcare delivery in America, how medicine is structured in America, and how we think about it philosophically. It's a huge lift, and we cannot do it alone. We must ask our national leaders to take a deeper involvement in healthcare and to seek solutions with those of us that are providing it at the bedside.
You know, that was perfectly said. Thank you, and much better said than what I did. But a couple of things that pile on with what you just pointed out. First, Medicare reimbursement to hospitals is being cut. Sequestration has had a major effect. We're still hurt by the wage price spiral. Everyone is. But in this situation, and that's why I think it was so important what we heard from Dr. Watson early on about rural hospitals trying to get patients out. Patients with time-sensitive diagnoses are not getting the care we need because we don't have the staff, or we don't have the ability in the beds. For a long time, we were overbedded around this area. We are not overbedded. We might argue that we're underbedded. We're certainly understaffed. And nursing, as an example, nursing school admission numbers are down markedly throughout the United States. So hospitals have not pulled out of the crisis. It is not so much a COVID crisis as it is a healthcare crisis. And if we have any sort of a surge this winter, any sort of a surge, I think we will be in a very, very difficult position. And we will not be able to wait long to pivot to all measures that we have at our disposal to try and keep hospitals as open as we can, because folks, it's not great. And in the meantime, Stanford & Poor's and Fitch and other forecasters are prognosticating that the healthcare industry is in for a significant downturn, and many hospitals are going to be forced with financial shortfalls and may close. So I'm with you. We're at a little bit of a precarious tipping point right now in healthcare. It's not COVID right now per se that's doing it, but it's all these things that are come together. Dr. Ahmad Batras, Chief of Staff at the Kansas City VA Medical Center. I'm going to bet y'all are not immune from all these difficulties right now. How are things going out at the VA, Ahmad?
Not at all immune, and we're in the similar boat to everyone else mentioned issues with the staffing and with the beds. From a COVID standpoint, we're doing okay. I mean, it's the usual. It's kind of like steady flow of patients. It's just 9 inpatient beds, for example, occupied by COVID patients currently, and we have 76 active outpatient with COVID. So overall, it's been steady numbers over the past month or so. We do have 21 employees out due to COVID. And by the way, those 9 patients, 4 are due to COVID admission and 5 are with COVID admissions. So we haven't seen, luckily, any recent deaths due to COVID, which is really a good news. As far as the bed occupancy, we are running at 93% occupancy consistently in the past month for med-surg and 94% for ICU. We actually, this morning, we only have 1 bed available of the staffed beds. This is mentioned, we are down by 15 beds due to staffing. So we have major staffing concerns. And as everyone mentioned, nurse staffing is really been a struggle for us to to be able to maintain an inflow and again, people leaving the positions or moving on to other even industries and stuff like that. So that's really significantly concerning for us. Typically in the summer, we see way less occupancy rate for the inpatient beds. So you're exactly right, Steve, and everyone, with the concerns that in the fall, if any surge happens, that would be a problem.
Yeah, I actually think this fall, if we have a surge, could be our most difficult fall from the standpoint of taking care of all patients, not COVID necessarily per se, but all patients. And I'm worried. I'll be honest, I'm a little worried. I was talking to a person who just got into medical school, and she was doing some work as a nurse assistant, not med school, she was going to nursing school. And she was doing some work as a certified nurse assistant on the floor. She said, I'm not sure I made the right career choice because people are so stressed. And you know, if you don't have enough nurses and you stress your nurses too much, then you're challenged. And then that's not good for patients. It's not good for the nursing profession. And the nursing profession is at the heart of medical care. And when you really want to deliver great care, you have a great nursing staff. And in our inpatient beds, that is just, that is really critical. I think perhaps the most critical link of all medicine. Dr. Heather Harris is the medical director at Hayes Med. Heather, how are things there? That's too many H's for me, Heather. I'm sorry. You just have to change one of your names.
I'm kind of fond of it myself, though.
Yeah.
Yeah, I mean, we're having echoing the same things you guys are having. We were closed to transfers on Monday. With our staff beds were full already out here. Now today we're better. So there does seem to be a lot of variability from one day to another. We had 11 COVIDs on Monday, which percentage wise compared to all of your guys' size of hospitals is pretty good. We're down to 5 today. We've had 2 deaths. I mean, I think that the thing that we're seeing, it's really affecting those immunocompromised patients as well as those elderly patients. That seems to be the pocket of patients that continue to be sick and hospitalized. So we continue to encourage, the care of families around those individuals. Hopefully the new vaccine will give them another boost. But yeah, same concerns with the fall. I mean, in the winter, if we're already, on August 22nd closed for transfers, that's a little concerning for what, December and January may look like for us too.
Boy, we know, don't we, that those are the months that they started getting it in November, then December, January, February, March. Those are the hard months from a medical care standpoint for medicine patients in hospitals. And when we're closing in August, we were out for a few hours 2 days ago for time-sensitive diagnoses like stroke and heart attack. If you're doing that in August, that's trouble. That's trouble. Dr. Antonios, Senator Antonios is the Chief Clinical Officer at Ascension Via Christi. He does a great job as well, and he is with us today. How are things in Wichita, sir?
Good morning, everyone. Thank you, Dr. Stites. I think I'll probably repeat a little bit of a similar story to everybody else. We thankfully are not at the same level of we were with Omicron, but we are still dealing with COVID. COVID is not gone from our community. As of last night, we've had across our system 25 patients. We've got 4 in the ICU and a patient on the vent. So there's still some degree of illness. Thankfully, it is a lot less than the prior wave. I did want to take an opportunity to mention something, and I got reminded by Dr. Harris when she talked about immunosuppression or immunocompromise. And it's kind of interesting because this COVID journey has been a story about immunity. I did just a little bit of internal analysis of our data. Obviously, this is not obviously validated for any kind of comorbidities or anything, just some rough calculations at looking at the number of people who get hospitalized out of all of the patients that visited our ERs, just to kind of see maybe that's some sort of a surrogate endpoint for what happens with patients throughout the last 2 years. And interestingly, I found that during Alpha, we had about around 40% of admissions. So basically out of every 10 patients who visited our ER, 4 of them got admitted because, again, at the time, there was a lot less immunity, there was no vaccine, there was less people who had been exposed. Fast forward through the various different waves, we've seen that it had dropped to 35% during Gamma and then a little bit more through Delta. At the latest surge that we saw with BA.5, it was really down to about 15 to 20%. Obviously, there's fluctuations in all that data, but my point is, over time, immunity has been effective in reducing the rates of hospitalizations. So it's a testament to the power of immunity. We all know, we all studied in medical school, the power of immunity. And I guess I'll also, again, take the opportunity to remind everyone, be up to date on their boosters, immunity. And I know that we are talking about a new vaccine that's going to be potentially on the market here soon. So we shouldn't forget that what is going to improve things will be immunity. Unfortunately, what still impacts hospitals is, even though things are better, but when someone is sick from our staff, they still have to be at home, and that further strains the challenges of staffing that everybody has mentioned. We've made some good progress in our staffing. We are intensifying our efforts to make sure that we have good recruitment and retention. And we have worked really hard at creating a very inviting environment for everyone to feel valued, which has been successful because we do see people seeking our health system for employment. But there are still challenges, obviously, like the whole industry.
Yeah, the industry is under significant pressure, so thank you. And thanks for that excellent reminder about the importance of immunity and immunizations. Dr. Jim Stewart is the CMO at North Kansas City Hospital. James Stewart, but Jim, how are things going up in North Kansas City, man?
Well, I hate to sound like a broken record, but it's the same story that everybody else has had. We currently have 20 patients in the hospital with COVID. There are 8 more that are out of isolation and recovering. 2 of those are in the ICU. Capacity is a challenge for us as well, and we're running most days over 90%, and we have 16 employees out right now because of COVID, but doesn't sound like a lot, but if you take the staffing challenges that are already present and add 16 off because of COVID, it does make a difference. As of this morning, we had 7 patients waiting in the ER to get beds to come upstairs. So it's the same story here. Staffing is a challenge, and I would agree that the numbers that we're seeing now are winter numbers, and so if it goes up proportionally like it has in the past, then it's going to be tough this winter.
Yeah, and I think people should be a little concerned about the fact that we are struggling around bed capacity now, and part of that's just staff out sick. But the bigger problem, I think, is we've seen the Great Resignation. 20% of people have left healthcare, as Dr. Dishman mentioned. Dr. Michael DeVorn is Surgeon Chief Medical Staff President at Olathe Health. He could not be with us today, but he said that's their numbers. They have 10 positive COVID inpatients, 2 of them in the ICU, 1 is on a vent. They also have 9 of their associates out with COVID. Dr. DeVorn adds, the biggest effect COVID has had on our health system is staffing challenges, something all healthcare systems are experiencing or have experienced. Our COVID positive numbers, including patients and staff, which have been at very reasonable levels for quite some time. This is a problem of people not here to do that work. As COVID becomes just one of the many diseases we treat, we remain vigilant in maintaining safety and supply chain best practices. I can't tell you how much this is all true for all of us. We're struggling around this. We're struggling around the impact. And we said before about how much harder it is financially, and that's true. Dr. Adiga, I think you may have texted me about this, or someone did here a moment ago, and mentioned that one of the challenges for hospitals is, unlike a business where you can pass on costs, hospitals can't really pass on costs because you're on fixed contracts between Medicare, Medicaid, and commercial insurance companies. So it's not like you can pass on the costs. You really have very few patients who are going to really pay full dollar, and so as a result, your budgets get worse, and you have to find other ways to try and make money. So it is a struggle inside healthcare. Dr. Dig, any special insight now in your role as interim CEO?
Absolutely. I mean, like any other industry, this is one area we are not able to negotiate with anybody, whether it's a commercial insurers or Medicare. There is no negotiation there. So we are stuck with what we've got, and we have to deal with our operating costs. So that puts us at even more strain, and that's one of the main reasons why a lot of the smaller hospitals in the rural areas are shutting down.
Yeah, and I think urban hospitals are under amazing stress. It also will take as another new variant that affects our staff, makes that harder, pushes our inpatient populations up higher. That's going to be a struggle. We've never gone into a fall like where we are today. A new CDC report warned that progress against deadly antimicrobial infections, especially those because of resistant ones, reversed course during the first year of the COVID-19 pandemic. After years of steady declines, antimicrobial resistant hospital-related deaths and infections from 7 pathogens grew from 15% between 2019 and 2020. Dr. Hawkinson, concerning.
Yeah, we know this has been continued to increase. I think it is concerning. We have to do everything that we can locally as a nation, in those health systems with those providers. Certainly we have a robust program to help reduce that here at the health system, but it also is really down to those individual providers and just really trying to do their part. It is one more detail that we have to continue to have in the forefront of our minds when we are looking at treating and diagnosing patients, for sure.
Yeah, I think that is a big deal. Okay, well, let's check in with Alexis and see if we have any reporters on the line or who have submitted questions or community questions. Alexis, tell Sid.
Dr. Stites, we have so many community questions. First, I want to check back in with the reporters who we know are tuning in and see if they have any questions off the bat. Looks like we're good. So let's get to the community questions because this has really sparked interest and always does when we hit on this topic. Claudia wants to know, what are the chances of getting long COVID from a new variant if you are fully vaccinated and boosted?
That's a great question. I'm going to just turn to Dr. Scrimshire this time instead of Hawkeye. I'm going to pull a fast one. Jim Scrimshire, infectious disease doctor at LMH. What do you think about long COVID?
I can't remember
bad.
Yeah, it's not, it's probably for me one of the scarier things. I don't know the exact percentage of people who go on to develop long COVID. It's higher, I think, than we originally thought. And I know that vaccination decreases the likelihood that you develop it. And as every provider on this call knows, a lot of the symptoms that these, quote, long haulers are dealing with are just, they feel untreatable for the most part, and it's really difficult to sit there and have to say to a patient, I don't know when you're going to get better. I'm sorry, this is terrible, and I don't know what else I can do to make it better or make you get better faster, and ask for patience. But yeah, vaccination is one of the things that you can do to help decrease the likelihood that you'll go on to develop long COVID if you do happen to get infected.
Rita has a question, piggybacking on that response. Rita wants to know if our vaccination rate is getting any better across the state and if a higher vaccination rate will make any difference at this point.
Dr. Dishman, what are you seeing about vaccination rate across the state of Kansas these days?
So I think as we look across the whole state, we're seeing a pretty static picture. We've delivered about 110,000 vaccinations, and that's going to be about 70% of our community once you figure in boosters and everything else. And I think what we're seeing is we've vaccinated the people that are going to get the vaccination, and we continue to encourage people, as was mentioned before, wash your hands, wear your masks when appropriate, as outlined by the CDC, and get vaccinated. But I think we have reached a static state for vaccination across not only Kansas, but across the country.
Lisa has a question, and this is a common question that we see. Lisa writes, I had my first booster in November. I was going to get my second booster, but then I got COVID. I want to get my second booster, but should I wait and get the new one at this point?
Well, that is a common question, and it's a great question. Lisa Hayes, what are you telling folks?
Well, I'm typically telling people that they should wait for another booster until 90 days after their last infection. However, with that promise of the new bivariant vaccine on the horizon, I would maybe wait and get it when it's available, if it were me.
That's what I've been saying, Hawkeye. Check me.
Yeah, no, I think, and I heard a good answer from Dr. Fauci today. Certainly, if you have not had a boost in the calendar year of 2022, and you were in that high risk category, especially if you're 50 and over and you're due for that, you really probably should have had it. But now, as we know, the news with the new bivalent vaccines are coming out fairly quickly. Really judge your own risk. I think if you were able to get it today, just a dose of the regular vaccine, you probably really wouldn't be protected for 2 weeks. By that time, I think the new bivalent vaccines from Pfizer are going to be out. So I think it's understanding your risk, but for most people, it's probably going to be best to wait until the new vaccines are rolled out here in probably 10 days, 2 weeks.
I think that's right. I think we'll expect to get them very soon. All right, Alexis.
George would like to know if any of the doctors are seeing any change in the mood about COVID in your specific communities.
Kim, I'm going to ask you that question because you guys are in a lot of communities. What do you think?
I do think, and this is just anecdotal, but I do think that there is somewhat of a relaxed approach to COVID and the risk as compared to 2 years ago. We continue to follow CDC guidelines within our hospitals, of course, as far as masking and isolation and all of those things that we all do. But I've just noted personally that there seem to be fewer people out in the communities who are adhering to some of the guidance that has been given, and even their approach toward vaccines has been somewhat relaxed as well. So I do agree with that. We'll see how it goes this winter and if that changes everyone's outlook.
Yen Liang has a question. Yen Liang would like to know, do we have vaccines that could prevent us from getting all kinds of variants?
Well, I don't think we can prevent from getting all kinds of variants. The question is, how well does it keep you safe if you get one of those variants, Hawk?
Yeah, I think that's right. You know, again, we know antibodies are very, very specific. They are a part of our immune system. It is still easily, you can still get infected really by any variant. The vaccines were meant to protect you against severe disease, and as we were talking earlier before the show, we know that the vaccines have continued to provide protection throughout all the variants, so I think that is the important message to remember. Now, with the new boost, once you get a boost, you probably do have some protection against the variants that we know about and the variants we don't even know about yet because of that evolution that your immune system has taken since those first vaccine doses. So you will get some minor effect on prevention of infection, probably for 3 to 5 to 6 weeks after that vaccine. But overall, we're not looking for prevention of infection from the variants. We are looking for prevention of hospitalization and severe disease. And we know these vaccines continue to do that very well.
Jean has a question. Jean wants some clarity on the CDC transmission map. Jean wants to know, how do you explain the transmission map showing almost all the U.S. as red, high, and only 1.43% as low?
Yeah, I think our point is in reference to where on the New York Times heat map, the way we were looking at it is, the U.S. is still high, there's no question about that, but a couple of quick points to be made. First of all, publicly reported data has gotten so bad that it's hard to know, right? Because the reality is that people are doing home tests, not just here, throughout the world. And a lot of people have just given up testing a lot. Second of all, what we know is wastewater numbers are clearly on the decline, which is good news. Third, it's relative to where we started a few weeks ago. It doesn't mean there isn't still high transmission. There is still high community transmission. There is no question about that. We are still in a red zone in Wyandotte County because it is still high community transmission. But the number of hospitalizations has decreased. The number of patients who are getting critically ill has decreased. And to the point that was made earlier on the broadcast about Dr. Antonius about the difference in how patients are in the hospital, that is, you know, we, just like, and I'll come back to you just a minute here, Sam. Historically, we had 30 to 40% of patients in the ICU. Now about 10% of patients are in the ICU. And it's very predictable who's going to the ICU and is getting sick. And some folks are either A, or were never vaccinated, B, are immunosuppressed so much that they probably didn't take the vaccination, meaning it didn't respond to it. Or third, they have all these other really terrible chronic conditions. Dr. Antonios, thoughts from your standpoint?
I agree, Dr. Stites. So really, it's been an interesting, we have to look at the last 2-3 years, and the journey with COVID has really been the story about immunity. And what happens when you go from a country that has had no immunity at all for a very novel virus. In fact, we all called it novel at the beginning. And then, so no one was immune, higher risk, a lot more mortality, a lot more people needing to be hospitalized and end up in the ICU. And gradually, as vaccines have come along, and as some degree, to some extent, of natural immunity has built up in the country, we have seen those improve, which is good. What we also know, in addition to that, even though that should make us feel a little bit better about what's happening for the population as a whole, every person still needs to judge their own risks. And that's why we should not forget that we all have an immune system that could either because of health issues weaken, or just because of the passage of time lose efficiency. So we have to keep tracking what the CDC is recommending, what the professional societies are recommending, and keep our health up to date with all the necessary boosters. And I also agree with your comments about data. With all the at-home testing, we now don't have as accurate as data on in the communities as what's going on. We think we might have some directional ideas of what's going on with COVID, but really it's just become harder to know what's going on in the community, because as you know, people can get tested a lot of places, and at-home tests are making it more difficult to get a clear picture.
Yeah, I think that's why you kind of rely a little bit on wastewater testing, but I'm going to get my H's right this time. Watch this. Dr. Heather Harris at Hayes. Hey, 11 patients, that's a pretty high number relative to some of the inpatient size and distribution, et cetera. Are you seeing that other hospitals in western Kansas have a little higher census? Are you nervous about immunity and lack of follow-up vaccinations? Give me some insight into what you're thinking there.
Yeah, so what we've seen so far is the younger patients are immunocompromised, some kind of underlying cancer or medication, but the gross majority of those inpatients are actually the elderly, 90 plus, 85-year-olds from the nursing home. They're just making them very frail and falling. I mean, the good news is, like you all reported, they're not going to the unit. They're not intubated, but it still takes them a long time to recover. And then a lot of them can't return home because they're too weak. And so that's kind of what we're seeing here locally. Still the majority, some are from Ellis County and of course from the surrounding counties as well. And then there becomes the whole challenge again, which we've all been dealing with, is once they're better and able to leave the hospital, is finding that discharge place for them outside of the hospital if they can't return home. That continues to be a large hurdle in the system, and will probably continue to be a hurdle with staffing issues as well.
All right, Alexis.
Ruth Allen has a question. This is a layered question. Is hospital capacity across Kansas due to shutting down healthcare facilities? Isn't there any money in the American Recovery Act to help? Would expanding Medicare help? She also writes, thanks so much for bringing these experts together again.
Yeah, I think that's a layered question. I think the challenge in hospital capacity is, first of all, we didn't start out overbedded. Historically, there were that thing, well, there are just too many hospital beds in our area. That's not really the story now. Second of all, we lost staff because they left healthcare because, COVID's bad, right? COVID's bad, dude. And I think that when that happened, it made us more vulnerable. And then we saw cutbacks in reimbursement. Medicare cut reimbursement this year, so that hurt hospitals. Kansas did not expand Medicaid. That's hurt hospitals. And then in addition to that, there's just a lot of chronic disease and illness. And it feels like this is not in the national conversation. Dr. Dishman, I think you made a good plea. It needs to be in the national conversation. I think our healthcare system is in a very difficult place right now. Kevin?
I agree, Steve. You said it very well. We've got to bring this to the forefront of the national consciousness. This must be on par with our financial health. This must be on par with our infrastructure health, because healthcare is and always will remain personal to every single one of us. and a key component of the quality of life that we enjoy in this country, and we need to start treating it like that.
Yeah, and we even touched on the mental health aspects of this, Dr. Stewart, and I know that's been a struggle for all of us, but how are things up there with North Kansas City too?
Yeah, the healthcare crisis has made the whole capacity issue even worse, because when there's no place for the people with mental illness to go, they have to take up a bed in our facility, and it's just exacerbates the problem and makes everything else worse.
Ahmad, the VA government, the VA is a part of government, really, but you guys are suffering the same struggles we are.
We are. The VA as a whole is actually looking into that staffing shortage area and even trying to increase staffing over what we normally run our hospitals with, so that we can stay prepared for this. And of course, the efforts have already started on this, but we're really working really hard to fill the vacancies that we have existing. And yes, we added some more positions even over our normal staffing, so that we can be prepared for those kind of emergencies and actually use the VA system where we can have those staff that can be traveling between VAs when needed. But we're still struggling. I mean, it's the nurse staffing are coming from are competing. We are competing with all healthcare industries, so it's not, the VA is not immune to this. So there's no like dedicated staff only to the VA. So obviously we are competing for the pool of applicants that we have, and unfortunately there's major shortage in that pool. As you mentioned, Steve, the nursing schools admission rates are declining. While the demand is increasing. So there is a problem with this equation.
Yeah, and I think the other problem we've ran into is that nurses who are at the, I think have been at the front lines of this and really are at the, I mean, this is where a lot of this is turning. It's true for other things, social workers, dietitians, respiratory therapists, et cetera. But the nursing staff at the bedside is where a lot of this is turned, and there's been a wage increase for nursing, which is great because they're very underpaid, and so I think the struggle though is as wages go up, hospitals get less, then you don't have enough ability to continue to do that. I mean, it's just a struggle. Lisa.
Yeah, I was just going to weigh in on that. You know, we talked about the mental health crisis in our community and how those patients are waiting to go to an involuntary hospital. But we've also got a mental health crisis among our staff. And, you know, whenever you go to a restaurant, you see the signs up, be kind to the staff that showed up. I just want to encourage our community that, you know, we have a lot of newer staff. They're new on the job. They're learning. They're the ones that showed up. Let's be kind to them and show them grace, just like we would at our local restaurant.
Yeah, very true. Vilifying the staff doesn't help make anything better. Samer.
Yeah, so this was a great question from the public, and it's got a really, for me, I'll make it simple. The answer is yes and yes. Some of the recovery funds that are available would be helpful, so I think that should be considered. And expansion of Medicaid would be helpful, and I do think that's a point to be made. And my last point is, let's just also think about those patients who today don't have access to care because of the lack of expansion of Medicaid. Those are potentially patients who are either getting sick with COVID or otherwise, and come into an ER and not being able to afford their care, or worse, skipping going anywhere, dealing with their COVID, not getting access to care. And that's a societal burden that also is not being looked at. So the answer to those two questions is simple, yes and yes.
It is simple, isn't it? The next part of the question is harder though, how to get it done. All right, Alexis, maybe one more question.
Carol has a question about teachers and students, and so does Barbara. So I'm going to morph these together. Barbara wanted to know about how to protect teachers when most of the kids, and a lot of the schools, kids are no longer wearing masks. And then Carol writes, do you have any suggestions for teachers and or students this year? I have a relative teaching in the Olathe School District that just tested positive. her third time of having COVID?
Hawk.
Yeah, I mean, I will start with, the individual. So first, understand your risks. Also, be boosted, be up to date with your vaccination. The other thing you can do is wear a mask. We know masks provide protection for the wearer. Now, I know there are inherent difficulties when you are teaching, kids being able to see you speak, especially if they have other like hearing impairments or something like that. I understand that. You can still distance. Also, please try to make sure as much as possible, and some of this is restricted because of the engineering in that school, but having good airflow and ventilation in that room. If you can open windows, that's great as well. Those are the few things that you can do to help really reduce your chance of getting COVID.
Yeah, it's tough because it's really the same questions you would have if you go into a mall or if you have to work inside a business, et cetera. These are just challenging, times.
Just like nursing shortages and capacity, we know that there is significant teacher capacity issues as well. Not only shortages of teachers, full-time teachers, but also substitutes as well. And so, it's extremely important to keep all those adults in that school as healthy as possible.
Folks, this panel you've heard from today, these are great people. As hospitals, we're sometimes competitive, but I'll tell you what, as colleagues, this is an amazing group of folks. Every one of these chief medical officers, chief clinical officers, infectious disease docs, these are special folks and they work at special places, and all of us are dedicated to trying to help keep you healthy. So thanks to all these folks who are on this conference call today. We know your time is valuable. We appreciate your commitment to public health. We appreciate your commitment to trying to do the right things about what's going on. We hope you heard a message today. The message we always want to project is one of hope, because we are hopeful. We're a hopeful group and we try and do the best we can. But it's also one of reality. This fall, we have to buckle in. This could be a bumpy ride. We're going to need your help. And if we start coming back to you asking for more help with masking or anything else, we hope you listen to us, because we're only trying to do this for you. So thanks for being with us today. Just a quick note, Len Dawson passed away last night. Len Dawson was everybody knows I'm a big Chiefs fan. I love the Kansas City Chiefs. I bleed red and gold and white and yellow, whatever our colors are. And I remember that iconic picture of Len Dawson in the halftime of the Super Bowl, leaning over, smoking a cigarette. But the man lived to be 87 years old. He's a Hall of Famer for two reasons: his playing career and his broadcast career. For those of you who don't remember, Len Dawson started one of the first football review shows that went over the week's prior actions that was done on national television. Len Dawson has two brilliant careers, a brilliant light here in Kansas City. Alexis, what do we got coming up tomorrow?
Tomorrow we have a powerful program. We know today is the 6-month anniversary of the beginning of the war in Ukraine. Well, tomorrow we're going to talk about the emotional struggle it comes to when children are watching all the coverage. They might be overwhelmed by the constant news. This episode first aired after the Russian invasion began and included some very important ways to make sure your kids are doing okay. We're going to have that encore episode for you tomorrow morning at 8. And then we'll be back Friday.
30% of us will develop a hernia in our lifetime. I'm Jessica Lovell. Coming up Friday, meet the surgeon with a whole new approach to repairing a hernia, and be prepared to get up and walk. We'll see you then on these social media channels.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.